Good morning, one and all. So today's IC topic is diabetic retinopathy. Is in prevention better than cure? Diabetic retinopathy is emerging ocular pandemic. The widespread coverage of the topic is done in most of the conferences. Awareness among the patients, general ophthalmologists, and physicians about the gravity of the problem remains bleak. So early and timely diagnosis alters the progression and the outcome of this disease. And the main aim of this IC is to discuss about the screening protocols, the treatment modalities, recent advances in diabetic retinopathy to be known for the budding as well as the general ophthalmologist. So the first topic of this session is by Dr. Deepa MG, Associate Professor in Government Medical College, Ernakulam. Her topic is diabetic retinopathy, when to intervene.
Good morning. I'm Dr. Deepa, Associate Professor of Ophthalmology, Government Medical College, Ernakulam. Please pardon me for my voice because I've been down with a fever. Well, I'm talking about what are the situations in which we have to intervene or we have to treat in diabetic retinopathy. Compiling the data from various studies across the world, around 35 studies covering 25,000 people, it is seen that among those with diabetes, 35% has diabetic retinopathy, around 7% has PDR, the equal percentage has got a diabetic macular edema, and about 10% of people have vision-threatening complications of diabetic retinopathy. So this itself shows the importance of the right diagnosis and the right and timely management so that we can save vision as well as preserve the quality of life of many of diabetic retinopathy patients. So the relevance of the topic is quite obvious. The treatment options that we have is laser photocoagulation, intravitreal injections, pars plana vitrectomy, and medical management of diabetes, as well as the coexisting comorbidity conditions like hypertension, dyslipidemia, renal anomalies, etc. Coming to laser first, what are the indications for pan-retinal photocoagulation? As you all know, it is mainly proliferative diabetic retinopathy, low risk being an NVD less than 1/3 dis diameter, NVE less than half dis diameter, and high risk PDR where NVD is more than 1/3 dis diameter or NVE more than half dis diameter with vitreous or pre-retinal hemorrhage. And any NVD with vitreous or pre-retinal hemorrhage is an indication for PRP. In low-risk cases, sometimes, depending upon the severity of signs, systemic comorbidities, patient circumstances and all, you may wait for a PRP, but then ensure that the review is done strictly in 2 months. At the same time, in some other low-risk PDR patients with low compliance, pregnancy, systemic comorbidities, rubeosis, etc., we have to insist on a PRP. Another indication is diabetic macular edema, and the ICO classification goes like if there is no retinal thickening or hard exudates at the macula, there is no diabetic macular edema. When there is a thickening at the macula but not involving the central subfield area of 1 mm diameter, that is non-central DME, and if the central area is involved, that is central diabetic macular edema. The treatment options again are intravitreal anti-VEGF, laser photocoagulation, and intravitreal steroids. So in macular edema with no central involvement, we can wait, or we can apply a focal laser to the leaking microaneurysms if the thickening is encroaching or threatening onto the fovea. In DME with central involvement, the key factor that you have to see is the vision. If the vision is good, that is, if it is 6/9 or better, we have 3 options. We can observe, and then on reassessment, if it is worsening, we can give intravitreal anti-VEGF, or if the signs are severe enough, we can give intravitreal anti-VEGF straight away, and sometimes they may need a laser photocoagulation, combined therapy with anti-VEGF. If the diabetic macular edema with central involvement and visual acuity is less than 6/9, then definitely it should be treated with intravitreal anti-VEGF. Laser photocoagulation if it is persistent retinal thickening after 24 weeks also, and intravitreal triamcinolone alone can also be tried, especially in pseudophakic eyes. If the diabetic macular edema is associated with a proliferative diabetic retinopathy, intravitreal anti-VEGF, and consider repeat injections or PRP if it is not resolving on follow-up. If an associated epiretinal membrane or a vitreomacular attraction is present, a pars plana vitrectomy is advised. So we saw the indications, the general indications for laser, but sometimes in severe NPDR also we have to consider treatment. So what are the indications in severe NPDR? Especially in older patients with type 2 diabetes mellitus, when the patient is having a poor compliance or we have a difficulty in the evaluation of the fundus due to a very hazy retinal view, when the patient is preparing to undergo a cataract surgery, as the surgery itself can worsen the diabetic retinopathy, and if it is a one-eyed patient or the patient has already lost the vision in the other eye due to complications of diabetic retinopathy. So this, in very brief, are the indications for us to intervene, and the treatment options, the pros and cons of each of this will be explained by the coming speakers in the next coming sessions. Thank you all for your very patient listening.
Thank you, Dr. Deepa, for that concise presentation. And now I invite Dr. Sudha V, Professor and Head of the Department, Government Medical College, Thrissur, to speak about the interpretation of OCT and FFA, key points everyone should know.
So thank you, Dr. Manju and the entire Ernakulam team for giving me this opportunity. This is a very practical topic. You should know what OCT and what FFA you're going to do before you start upon any program. So first thing first, OCT should not replace a detailed fundus examination. It is not at all a replacement. Always look at the OCT picture as well as the fundus photo to give you a hint. Some things which you should know. There is an international classification now. There is something called layers, there's something called band. Now what is a layer and what is a band? Layer is an anatomical structure. So like if you have an internal limiting membrane, that is a layer. But the band is what you see on OCT. The layer and the edge. You are seeing that edge, that is the band. So layer is an anatomical structure. Now the things which do not have an anatomical layer, that is called a zone. So clear? So band, layer and zone. So you have a hyperreflective, that all you already know. Next is which color do you choose in an OCT? So do you like the false color? That is a very beautiful color. It's got all sorts of colors. But the problem with the false color is contrast is not too good. Second, the red doesn't mean that it is a very hyper-reflective structure. It's just a color. It's just a false color. So green is not really suggesting that there is a hyper-reflective, or it's not a staged set. So while the gray scale, the more white it is, the more hyper-reflective it is. So it is telling you something about the reflectivity. So for example, if you see this picture, you see the upper one, you are giving a beautiful, the outer layers, you are seeing all the two lines. But in the lower one, you are just seeing the red color. So the contrast is much better with the false. And if you see the epiretinal membrane on the first slide here, on the left side, you can also see the curves of the retina under it. So it's well seen. Now there are many scanning protocols which are available. Which one would you choose? That is important for you. These are all different protocols. What do you want to choose? So there are also a lot of printouts. Now which ones? These give you a lot of information. You just need to know what you have to do. So what are we going to assess? We need to assess the retinal thickness. We need to assess the morphology. We need to assess the map. How thick, where and what, right? We also need to know if there is some traction, and we need to know the outer layer integrity. So one line scan. What is a line scan? A lot of A scans are going into the tissue in one line. Right? So that number of A scans is giving you 1 B scans, right? And number of B scans is giving you a raster line scan. So what is it doing? It's just sending A scans in one particular line. So what will this give you? This will let you interpret that. B scan will let you interpret it layer by layer, the entire layer from the outer retina to the inner retina. So the changes which you can see in diabetic retinopathies on a B scan is traction. You can see drill, that is disorganization of the inner layers, and you can see cystoid spaces. So that is clear with the B scan. Now what is volume scan? So you see the next one. This is a cube. Can you see that painting, this color here, this thing? I'm sorry, I don't have a pointer. The first thing which is just showing you a square. It's not a square, it's a cube. What it means is there are lots of lines going in this 6 millimeter cube, both horizontally and inside it and vertically. So it is a cube or a 3D space which these lines are going and they are scanning for you. So it is color coded because it is supposed to show you at a picture the topography. So where it is high, where it is low, right? So the macular cube scan which is coming on the Zeiss machine, that gives you 128 into 512, which means that there are 128 B scans. But the B scan, each of them has 512 A scans. So right, so that is, so the more denser you go, the B scans increase, but the A scans are reducing. So the space is decreasing, but your resolution is reducing. Is that clear? So that is so what you should take. Now, so after that, once the cube has been taken, it cuts through that cube and gives you a 2D picture of your layer thickness at each level. So that is your topographical or the thickness map which you are getting, which the ETDRS grid will tell you the central thickness. I hope you understood this. This is just a cube, and out of this various levels are giving you that scan. So why is that? That is a raster scan. Those are line scans. But there are also something called radial scans. Now, why do you need a radial scan? Suppose you're looking at the fovea at one single point. You would like to see it from all directions, right? So that radial scan is important for the central point, for the fovea. So if you can see that picture here, the raster scan below has missed that little bit of cyst. But it is seen in the fovea because all directions have been assessed here. Right, so that is the importance. So you can get other things like serial printouts, and that is for OCT. So you just need to know how dense you want to go. The more denser you're going, your resolution is reducing. So don't go in for a general dense. Generally, you can do a raster, both vertical and horizontal. But if you want detailed pictures of the fovea, you would like to go in for a radial scan. And printouts for regular follow-ups. Now, when to use an FFA? Now, because of the OCT, our FFA indications have reduced. So, mainly it is now just before laser treatment for DME. But also many people use it as a documentation, right? So, that is there. The other conditions I'll be telling you, unexplained poor visions, I'll just show you the pictures. So, thing you should know about FFA, the main camera which we are using is just the posterior pole, that is up to vascular arcades. If you want to go wide field, you can go beyond that up to the vortex veil. So these are the FFA phases. This is in the first minute up to the last phase. So usually we take an FFA initially 1 minute rapid fire, and then up to 8 minutes you can take a slow picture, and you put these pictures together. So the first one is the color photo. The first picture is the early picture. The second picture is approximately a 3-minute picture, and the last picture is around a 10 minutes picture. So what is it telling you? The changes, subtle changes which are occurring along the time. So this one is neovascularization. The first picture is just showing you subtle changes, and it becomes much more active in the late stage. About DME, we need the early picture for treatment. So you see in this color photo, you cannot identify any microaneurysm. Where are you going to treat? So you need an early picture, but that must be an early picture because the late picture will not show you any microaneurysms. So this also, the late picture is important. Sorry, can I go just a little bit more? The late picture, yeah. Okay, thank you. The late picture has, if you can see, that is only used to identify whether this is cystoid macular edema of cataract surgery, post-cataract, or of a DME. How do you identify that? See the disc. See, the disc is shining in the second picture, which is telling you that this is not DME, but cystoid macular edema, right? Irving-Gass syndrome. Also, in the mid procedure, you can take peripheral images, which you should, because there also you can identify the blooming picture hyperfluorescence which is occurring. That is the NVE which is occurring. Now, sometimes when you cannot see anything in the fundus picture, this is not a very good quality, but still you are not able to see anything. But as you take those 4 pictures, you can see the beautiful NVE and NVI, which is NVE and NVD, which is coming up. Exactly, if you want to see unexplained visual loss, vision is just 6/60. The fundus looks perfect except that 1 or 2 hard exudates are there. Here, if you take that early picture, you are going to see the foveal network. So the foveal network needs an irregularity is seen in that. It's not the oval foveal network which you're seeing. So that irregularity also comes in the early picture. Of course, in this kind of a thing, when you can't see anything in the fundus photo, you can see it all through the FFA. Beautifully it gives you. So thank you. A good image is an art. You have to learn how to take a good image, but much, much more important is your interpretation and how to use it. Thank you so much.
Thank you, Dr. Sudha, for that wonderful talk on how to interpret an OCT and FFA. I think all of us must have benefited from this very basic class on how to interpret this OCT pictures and FFA pictures. Thank you. Next, I invite Dr. Danya to speak on non-surgical treatment options in diabetic retinopathy. Dr. Danya is the Senior Associate Professor in Government Medical College, Ernakulam.
Good morning, one and all. And thank you, Ksos, for giving me this opportunity. My topic for today's discussion is non-surgical management of diabetic retinopathy. As you all know, it is one of the leading causes of blindness worldwide, and PDR and diabetic macular edema being the retinal complications which results in irreversible blindness in diabetes. And what are the risk factors for this? Raised blood glucose, lipid and triglyceride levels, hypertension, anemia, advanced diabetic nephropathy, and pregnancy being the risk factors associated with progression of diabetic retinopathy. And medical management, I'll be telling in a nutshell. The first thing you have to do is a systemic control of diabetes mellitus and the associated risk factors. And in mild to moderate non-proliferative diabetic retinopathy with no macular edema, you have to observe the patient regularly, screen, and to find out whether there is any progression in the diabetic retinopathy. And in severe NPDR and proliferative diabetic retinopathy, you have to consider pan-retinal photocoagulation. And diabetic macular edema, you can do either a focal or grid photocoagulation, intravitreal anti-VEGF therapy, or intraocular steroids, depending upon whether it is a center involving or a non-center involving macular edema. And control of the risk factors, as I told you, the intense glycemic control brings down the progression of the microvascular complications, and a tight control of hypertension. And recently, 2 pivotal studies have published regarding the beneficial effects of fenofibrate and candesartan for the treatment of hyperglycemia and triglyceridemia, which can reduce the progression of diabetic retinopathy. You can see in the picture how drastically the hard exudates and the hemorrhages have been decreased after the strict metabolic control of statins with statins and antihypertensives. And next, in detail of proliferative diabetic retinopathy, a non-high-risk PDR without diabetic macular edema, you have to do a 2 to 4 monthly follow-up, and immediately you have to do a pan-retinal photocoagulation if high-risk PDR develops. In high-risk proliferative diabetic retinopathy without any macular edema, also you have to do a pan-retinal photocoagulation. And PDR with diabetic macular edema, you have to do a combined approach with anti-VEGF and pan-retinal photocoagulation. So this is a flowchart depicting how to manage the proliferative diabetic retinopathy with diabetic macular edema without and with fractional diabetic retinopathy. You can see in the first with DME, if it is a focal DME, you have to consider a focal laser therapy and followed by PRP. And if once the DME regress, then yes, you have to observe. If it's not regressing, you have to do an anti-VEGF or Dexoran implant, and after that you have to schedule the pan-retinal photocoagulation. And if it is without DME, you have to do an immediate PRP if it is feasible. Then if it is not feasible, then you have to do an anti-VEGF therapy. And tractional diabetic retinopathy with or without vitreous hemorrhage, then you have to do a consider pars plana vitrectomy for this patient. Okay, so what are lasers? These are time-tested, evidence-based fundamental treatment for diabetic retinopathy. Rapid strides makes the laser treatment more selective and targeted and less destructive. Otherwise, it will cause destruction of the photoreceptors and can result in the night vision problem or color blindness or contrast sensitivity post-laser. And this is not associated with serious complication as in for anti-VEGF. So indications of lasers other than PDR in diabetic retinopathy is DME. If it is a non-center involving, you can use either focal or grid lasers. And in advanced diabetic eye disease, you can do an endolaser photocoagulation as a part of surgical management. PRP can also be done, has to be considered in a cases of non-high-risk PDR. The certain indications are if you feel that the patient will not come for follow-up, if there is a limited healthcare access for the patient, and in an old patient with type 2 diabetes mellitus, one-eyed, and pregnancy patients with pregnant patients and patients who are impending cataract surgery. How do this act? They destroy the hypoxic retina and improves the oxygen perfusion from the choroid to the viable retina. This is the ETDRS protocol to how to do a PRP. Argon laser or double frequency ND arc lasers are usually used for this, and you have to do about 1200 to 1600 burns, about 1.1 to 1.5 burn width apart. The size of the burns can be between 200 to 500 microns, duration 0.1 second exposure, and intensity should be between 200 to 500 millivolt. And this is a picture post PRP. You can see the white burns in the retina where the lasers have been done, and the area where the clear area, that is usually these lasers are usually done in between, covering the area between major arcades posteriorly and the equator anteriorly. Settings for focal laser is about 50 to 100 microns, 0 to 100 milliseconds, just to whiten the microaneurysm. About 15 to 20 spots are usually given, and this is usually given in diabetic macular edema. I told you this non-center involving, okay. And these are the types of pan-retinal photocoagulant advancements in types of laser: conventional laser, pattern scan laser, navigated laser, and micropulse laser. Of this, what is the importance of the pattern scan laser is that multiple burns are delivered in less time. So it is more comfortable for the patient because the exposure to light is minimal. And the navigated lasers with computer assistance, it tracks the retinal eye movements and automatically it will readjust and minimizes the exposure to light. And this also is more comfortable for the patient. And micropulse lasers are subthreshold lasers which spares the choriocapillaries and photoreceptors with no visible burns. And so the visual fields and the contrast sensitivity post laser is better and more accepted by the patient. The complications in the anterior segment and posterior segment you must be knowing, and main complications I feel is you should know is a color vision and contrast sensitivity and decreased night vision and permanent visual field defects post laser. And in the posterior segment may be ERM, choroidal neovascularization, choroidal detachment, and PVD. Next, I am going into detail with the treatment of diabetic macular edema. As you all know that it is a retinal thickening by accumulation of the intraretinal fluid in the inner and the outer plexiform layers of the retina at the posterior pole. The international classification of severity of the diabetic macular edema, you should know how to know the management. If DME is present, you should look for whether it is a mild, moderate, or severe. If it is mild, the hard exudates or retinal thickening will be away from the macula. If it is moderate, hard exudate and RT will be approaching the center but not involving. And severe means center involvement, retinal thickening with hard exudates will be present. And how do you manage the diabetic macular edema? All the patients with diabetic macular edema planning for intravitreal injections should take an OCT and also, if needed, fundus fluorescein angiography. OCT you have to look for in retinal thickening, foveal contour, VMT, neurosensory detachment, disruption of the inner retinal layers, and fundus fluorescein angiography you have to do whether the loss of vision is disproportionate to the clinical picture. If you think that it is an ischemic maculopathy, if you suspect neovascularization, and also for mixed retinopathy and non-responders to treatment. Other systemic investigations you have to do as following: FBS, PPBS, renal function, HbA1c, BP and lipid profile, and whether the patient on glitazones or not. And Dr. Deepa has already covered about what is center involving and non-center involving. So treatment of diabetic macular edema can be based on whether it is involving the center or not involving the center. And if it is not involving non-center involving, it can be not threatening the foveal center or threatening the foveal center. If it is not threatening the foveal center, no ocular treatment is required at time, but strict metabolic control of diabetes mellitus is needed. And if it is threatening the center, you have to do a focal photocoagulation to treat all the microaneurysm associated with the area of macular thickening, or gentle modified grid to the areas of thickening. You should avoid treatment of nerve fiber layer hemorrhages as well as blot hemorrhages. Now coming to the treatment of the center involving diabetic macular edema, the mainstay of treatment is by using intravitreal injections like ranibizumab, bevacizumab, aflibercept, and intraocular steroids. Mainly the intraocular steroids you give for poor responders to anti-VEGF as well as the patients with high-risk diseases like myocardial infarction and CKD. The intravitreal injections, they reduces the retinal neovascularization by inhibit VEGF, as you know, but you need repeated injections, and the patient compliance and adherence to the therapy is very crucial for the success of this treatment. This is the anti-VEGF spectrum you should be knowing, and dosage is different for all. And bevacizumab is an off-label use with increased risk of hypertension, stroke, and MI. Aflibercept has got a higher affinity, 200 times that of ranibizumab, but it is and the newer anti-VEGFs are brolucizumab and faricimab. The complications of anti-VEGF affects the renal status of the patients with diabetic retinopathy. Either a new kidney damage or progression of the existing renal damage can be there. And how do you give anti-VEGF injections? Monthly injections involves larger number of injections. It is not practical. How do you reduce that? So you have to do a loading dose followed by pro-nata, that is pro-nata regimen as and when required, and 3 loading dose followed by PRN for ranibizumab, and 5 loading dose followed by fixed monthly regimen for bevacizumab. Treat and extend is another modality of treatment which start with a monthly loading dose till vision improves or OCT thickness do not improve further, and follow-up is increased more than a month by 1 or 2 weeks, and if vision is not dropping, call after 8 weeks, and thus injections can be reduced to 5 per year. And non-responders, eyes which do not show more than 20% of reduction in CRT or no vision improvement after 3 injections, you can switch on to treatment to other anti-VEGFs or steroids. Intravitreal steroids, common ones are triamcinolone, dexamethasone, and fluocinolone. It is the first choice in patients with ISD, CKD, CVA, where anti-VEGF are not safe. And the special conditions in which you see diabetic macular edema. In pregnancy, anti-VEGF is not safe. In late pregnancy, observe till delivery or treat if not responding spontaneously. In center involving DME in early pregnancy, you have to give intravitreal steroids. And DME in uncontrolled hypertension, you have to control the hypertension and treat only if DME persists. And CKD, you have to do anemia will be the contributing factors and correction should be done. Ischemic optic neuropathy can also be the cause of non-improvement. And so etiology of DME is multifactorial, needs tailor-made treatment. And other indications of intravitreal steroids include presence of clump of hard exudates or intraoperatively for triamcinolone acetonide assisted vitrectomy. And so the take-home message in of my talk is early detection of diabetic retinopathy by regular screening has improved the visual prognosis in diabetes mellitus. And modern advances in the medical management of diabetic retinopathy has brought down the need for surgical intervention. And so prevention is always better than cure. Thank you.
Thank you, madam, for that systematic presentation, compiling all modalities of medical treatment in such a short time. Next, we have a vitreoretinal surgeon par excellence from our part of the country to talk to us on when a surgical intervention is needed in diabetic retinopathy. Inviting Dr. Mahesh G from Giridhar Eye Institute for the same.
Just a few points before that, I just added to Dr. A lot of PGs will be here, so whatever Dr. Danya has said, the complete thing is covered. Nowadays, we don't two things on DME. One, DME is not an emergency treatment. It does not require an emergency treatment like a AMD, where if you wait for 1 month, it will cause scarring. That is one thing I always tell. You can go slowly. So most of us will give PRN based monthly injections, no loading dose of 5 or anything like that. This is practical thing I am telling. Some of you are medical retina people treating. So give one injection, after 1 month see, then second injection, like that, based on that. Number 2, if the vision is very good, 6/9 or 6/6, you can wait with metabolic control. So we don't aggressively treat pure DME with very good vision. This is not my take, this is DRCR net recommendation. Number 3, there is nothing called grid laser now. There is nothing called grid laser now. Practically, none of the retina people give grid laser because the grid laser has been replaced by anti-VEGF injection. So focal laser and injections. So these are the two things. Focal laser to the leaking microaneurysm seen in fluorescein angiogram. So these are 3 things in DME, practical points. Now, my talk is when do we need our VR surgeon to save us? This us, I presume, is medical retina people. Okay. Medical retina people, not general ophthalmology. General ophthalmologist has another, they have to detect the disease and refer when needed. So this is medical retina people. So medical retina persons are needed in India because of the enormous number of diabetic retinopathy in India. So 90% cases can be managed by medical retina people. Like, so that is what I am telling. Us means medical retina specialist. More than, if you get a fresh diabetic retinopathy, there is 1 out of 3 chance that it is going to worsen with your treatment. That is for sure. So that you have to tell. Okay, this is this also is old ETDRS that also shows it prevents vision loss only in 50 to 70%. So if you start treatment, 1 out of 3 will worsen. So I always tell the patient, communication is very important. You have to tell that there is a chance of 70% chance that you are likely to remain like this, but 1/3 of people will worsen. And put it on the patient's head that because you have a diabetes which cannot be cured. So this 1/3 will go, they are going to come and tell you that you treated and my vision reduced. So every 1 out of 3 is going to tell you this. So VR surgeons are needed. So how I counsel, yeah, I will show some my collection of cases. So because in my case I do laser, I do surgery. So that is no problem. So I tell, if it is not working, I will do surgery. That is okay. But this is not possible in a medical retina. Like DME not responding to treatment. You give 1 injection, 2 injection, nothing is happening. Look at the OCT. There is a epiretinal membrane or a taut hyaloid. How much ever injection you give, it is not going to worsen, improve. So that biomarker or epiretinal taut hyaloid in the OCT, that will tell you even if you inject. So these cases will require vitreoretinal surgery at a later date depending on the visual acuity. So this is not going to respond. Now this is another case of vitreomacular traction. How much ever, just see the OCT little carefully, see whether there is any taut hyaloid or membranes which will prevent reduction of, and never treat based on central macular thickness. Again and again I tell in every forum, don't treat that central macular thickness. That is not the thing. The configuration of the retina and the findings like this in biomarkers are more important than central macular. So this is post-operatively you get. So these sort of cases, be careful before keeping on injecting. 1 or 2 injections, they are likely to worsen also. Then there is something called recalcitrant macular edema. You inject 2-3 times, fine. Before treatment was left side. After treatment, you can see the edema is little less, but hard oxalate has increased, right? So this sort of recalcitrant, after 3 injections, if the vision and edema is not reducing, probably you have to reconsider. Either switch a drug or refer to vitreoretinal surgeon for vitrectomy. Many of these cases, recalcitrant edema likely to improve with vitrectomy. Taut hyaloid. This is very dangerous situation. You see white area, not blood. That is fibrous tissue. They are likely to worsen with laser. So preoperative and postoperative, these cases will require surgical intervention. Then this is another case, free macular fibrosis. This is called pre-macular fibrosis, that white area. So these cases, not only DME, PDR cases. So this case, if you give, what will happen if you give panretinal photocoagulation? The vascular element will become more fibrosed. So the fibrosis increases, macula will become more bad, vision gradually reduces. So if such a finding is there, pre-macular fibrosis, VR surgeon may be needed. So this is pre-operative and post-operative. Now this is another case. Already bleed is there, hard oxalates and pre-retinal bleed. Most probably this will end up with surgery. So probably medical retina person can give little laser and 1 month later see and then refer. Already tell the patient this will require surgery. We will try to give little laser and see after 1 month. So this is another thing. Now clearing the media, that is another area where VR surgeon is required, like asteroid, recurrent vitreous hemorrhage, but you don't see anything. It is very difficult to give laser also. Angiogram is a very useful modality in this. Cataract, vitreous hemorrhage and DME. Lot of patients come like this. There is cataract and DME is there and maybe little vitreous hemorrhage. These cases, ideal method is either you do cataract surgery, then refer it to VR surgeon for vitreous, or single stage you can do whole thing together. So these are all cases where VR surgeon may be needed in this. So this patient underwent cataract surgery with vitrectomy and additional laser, and this lower one right side is the final follow-up. So they do well with systematic treatment. So post phaco IOL vitrectomy, this is another case, left eye. In the OCT there is a taut hyaloid. So post surgery, even though the hard oxalates are the lower one is a post-operative 6/12 post phaco IOL vitrectomy. So these are combined cases which we do to improve the vision. Then scene 4 is PDR likely to worsen. You give laser, then he starts bleeding. So these cases, especially if you see a bad big new cells in fluorescein angiogram, be careful. You have to take Mungur jamium before starting treatment. So that is important, because patient will not understand the theory, all these percentages. So this is a important case that I always show. There is a huge NVD actually and 6/6 vision. And these are really, after PRP, 1 week later patient came with the right side picture, 1 week later. So very difficult to deal with these cases. So you have to talk to the patient initially, and this is another pre-treatment in left side. Post PRP, you can see that blood has become white, that is fibrosis. Neovascular element has become fibrotic. So this patient gradually lost vision, and then we did surgery. Crunch phenomenon is another thing. Many of us give excessive laser in heavy burns, and immediately 6/6 has become hand movements in 1 month. Crunch phenomenon, the whole thing contracts and detaches. This requires immediate surgery. So these are not easy cases. So crunch phenomenon, and there are cases like this. It is going to worsen fibrous tissue and new vessels, and after. So these cases you have to initially itself take the opinion of ER surgeon, and extremely ischemic retina, all these cases, and taut hyaloid fibrosis, premacular fibrosis. This is another case that I show, bomb in the eye, 6/6 and 6. Luckily we had, in fact, after the macula there is no perfusion. The whole area is ischemic. So 6/6 vision. So written consent also, we did laser and everything, and ended up with surgery. Both eyes oil removal, and over many years he is maintaining some 660. So with good communication. And scene 5 is already there is a vitreous hemorrhage surgical case. Probably a medical retina specialist can give little laser and then refer to the surgeon for further management. Recurrent vitreous hemorrhage is another indication for vitrectomy. Especially once or twice you can wait 1 month, 2 months and give additional laser if possible. Otherwise it's an indication for surgery. Combined RD, absolutely no option other than surgery. Then TRD involving or threatening macula is theoretical indication. Yesterday also in one forum I said, actually this patient is maintaining vision for past 7-8 years with 6/18, 6/24. These sort of stable cases we need not do a surgery. So in one visit itself, don't decide all these things. And another thing is, I have 1 or 2 minutes extra, no problem. No? So another thing is, if a patient comes with one eye bleeding and the other eye has a PDR, you have to tell the other eye requires treatment, but don't give that priority, because the patient has come for this eye. In fact, one of my colleagues gave right eye vitreous hemorrhage, left eye PDR. Right eye anyway we have to wait. By the time he started left eye surgery, left eye laser. 1 week later patient came and told me, by mistake they gave laser in the other eye. I came for this eye. It's a communication problem. It is actually other eye also has PDR, but give priority. Talk to the patient and give priority. Which eye to treat is more important. So take home messages are, we need medical retina specialists in India to tackle diabetic retinopathy burden. Smart India program was there yesterday. The incidence and prevalence, everything, huge volume. It is millions in India, and we need medical retina people. But medical retina people should work in tandem with retinal surgeons, and they should understand their limitations, but they should do a good work. Now, unfortunately, in the last, with the advent of biosimilars, the rampant use of anti-VEGF has worsened the scenario. 20 years back, I used to get fresh PDRs like some of these nice PDRs. I treat with laser. If it worsens, I will do surgery. Now, all of them are coming with bad combined RD or late stage, advanced stage, because of irregularly and improperly managed diabetic retinopathy. So that is what we don't want. So, and finally, the last line, communication skill is the most essential quality in any practice. Biju was talking about yesterday about ethics and etiquettes and everything. After all, it is a teamwork. Thank you very much.
Thank you, Dr. Mahesh, for that excellent talk and the practical tips on how to proceed in different and difficult situations. Information from hardcore via surgeon was definitely beneficial for all of us. And the next talk is by Dr. Manju Abraham, Professor and Head of the Department, Government Medical College, Ernakulam, about picking them early and right, screening protocols and management of risk factors.
Thank you, Dr. Danya. We move on to a less stressful topic. Nonetheless, it's very important, the risk factors and screening protocols of diabetic retinopathy. So the risk factors may be grouped as modifiable and non-modifiable. The non-modifiable are the duration of the disease, age of patient and genetics. Modifiable are the blood glucose levels, the blood pressure, serum lipid levels, microalbuminuria, and others like pregnancy, puberty, and anti-diabetic drugs. So we know that the retinopathy prevalence have come down now with a better control of our modifiable risk factors. Now let's consider each one of them. Two landmark clinical trials, the DCCT and the UK studies showed that intensive glycemic control reduces the risk of development and progression of DR. It is noted that a 1% decrease in HbA1c can reduce retinopathy development by 40%. And an early intensive control has benefits that last for up to 10 to 20 years, and we call it the metabolic memory. So it's important to, or it's recommended to keep the HbA1c levels less than 7, and earlier it is achieved, the better. Now, the Wisconsin epidemiological study showed that in type 1 patients, diastolic BP is a predictor to the progression of retinopathy. And the UK studies and the Euclid studies showed that every 10 millimeter increase in systolic BP can cause a 10% increased risk of early DR. And the study also showed that ACE inhibitors and beta blockers reduce the risk of DR. So our target BP should be less than 140/80. Now, what about dyslipidemia? The ETDRS showed a twofold increased risk of heart exudates when the cholesterol levels were more than 200. The beneficial effects of fenofibrate was seen in the field and the ECHORT studies, where there was a reduction in the DR progression as well as a need for laser photocoagulation. So it's ideal that you keep the cholesterols less than 200, triglycerides less than 150, and LDLs less than 70 in a high-risk patient. Now, coming to renal disease, in a prospective study done in type 1 patients, the risk of PDR increased from 7% to 24% after 4 years of onset of microalbuminuria. And the study also showed that gross proteinuria at baseline is associated with a 95% increased risk of DME. A decreased GFR as well as an increased urine albumin creatinine ratio significantly correlated with diabetic retinopathy prevalence. And if you see that in a previously stable retinopathy patient, a rapid progression is noted, the patient definitely needs a renal evaluation. And we also see that retinopathy remains stable in patients who are undergoing dialysis or who have already had a renal transplant. Now, what about diabetic medications? The DCCT showed that in the first 2 years after initiation of an intensive insulin therapy, the retinopathy can worsen transiently. So these people require careful monitoring every 3 months for the first 6 to 12 months. And you can even consider PRP before starting an intensive insulin therapy if the retinopathy is severe NPDR or early PDR. Now, the glitazones also increase the incidence of DME by 2 to 6-fold. These patients also require an adequate follow-up. Now, what about pregnancy? Retinopathy can rapidly progress during the second trimester. The effect may be transient. Women with the poorest glycemic control at baseline and those needing the greatest reduction in HbA1c in the first trimester are at higher risk of retinopathy progression. So it may be appropriate to perform a PRP before conception in severe NPDR patients to prevent further progression. Now, others like a hemoglobin less than 12 is associated with a twofold increase. A high BMI is also associated with a severe diabetic retinopathy. Now, the non-modifiable risk factors, we know the duration is the most important. The Los Angeles Latino studies found that each year of diabetes is associated with a 8% increased risk of retinopathy, and men are at an increased risk. Now, the second part of the talk is on retinopathy screening guidelines in India. The AIOS, Diabetic Retinopathy Task Force, and the VRSI have initiated measures to improve the screening in India so as to identify sight-threatening retinopathy early and to treat it promptly to prevent blindness. At present, there are about 3 million people who are at immediate risk of visual loss due to sight-threatening retinopathy. We have a high prevalence of undiagnosed diabetes in India, so we cannot restrict our screening to the known diabetic patients alone. So what AIOS have recommended is, though it is made appear not practical, all people with known diabetes on treatment or a single record of RBS more than 200 or an HbA1c more than 6.5, or a gestational diabetic, when first seen by a medical professional, should be advised a retinopathy screening. And the Government of India has also introduced a non-communicable disease register where the data of all diabetic patients should be entered, and these patients should be called for periodic screening. Now, how do we screen these patients? We have a community-based screening where screening should be done to all diabetic patients who attend the NCD clinics at the PHCs. We can do opportunity screening at the physician's clinic or the diabetology clinic, which appears to be the first point of contact for the patient. There are community outreach programs where door-to-door screening can be done to identify retinopathy patients. You can conduct exclusive retinopathy camps, and also you can screen at primary vision care centers. Hospital-based screening means diabetic patients that are seen at other departments are referred to the ophthalmologist. Now, the most practical way is a fundus photography by a trained technician using a non-mydriatic camera that gives you a wide field and which gives you high resolution images. All the captured photos are transferred to the base hospital. Now, if the technician can identify retinopathy, those images alone are sent to the base hospital. Now, if the technician is more confident and competent to grade the retinopathy, cases that are identified as more than mild NPDR are sent to the hospital. There, the ophthalmologist sees these images. A report is sent back to the NCD clinic or the diabetic clinic, and patients with sight-threatening retinopathy are asked to report to the main hospital. And the ophthalmologist should also see at least 10% of the normal images just to cross-check. Now, if the quality of the picture is poor, it may be due to the cataract or a small pupil. Those people should also be sent to the base hospital. Now, when do you screen them? A type 1 requires screening within 5 years of onset of diabetes. Type 2 at the time of diabetes diagnosis and then annually. Gestational diabetes does not require examination. A patient with a pre-existing type 1 or type 2 planning to conceive needs an eye examination prior to conception and should be monitored at least once every trimester or more if there is, depending on the degree of retinopathy. Now, the follow-up guidelines are no DR or a mild NPDR every year, moderate NPDR 6 months, severe every 3 months, PDR with no high-risk characteristics every 2 months, a center involving diabetic maculopathy with good vision every month, a non-center involving with very good vision or every 2 or 3 months. Now, if seen by an optometrist, a patient with severe NPDR, PDR or a diabetic maculopathy should be immediately referred to the ophthalmologist. Now, to sum it all up, the ophthalmologist should ensure a timely detection of STDR by a periodic screening. A prompt treatment should be initiated to prevent blindness. You educate the diabetic patients and create a public awareness on this blinding condition and refer the patient to the physician for better control of the systemic risk factors and other complications of diabetes. Thank you.
Thank you, ma'am, for stressing the importance of screening and risk factors of diabetic retinopathy and its treatment, the essential essence of this IC. Well, what is currently trending everywhere is artificial intelligence, and we don't want to miss out on that. Inviting Dr. Sindhu Enam, Associate Professor, Government Medical College, Ernakulam, for a talk on the same.
Good morning, everybody. I'm Dr. Sindhu Enam. I'm going to talk on artificial intelligence in diabetic retinopathy, exploring AI's role in early detection and treatment. According to ICMR India Diabetes Study published in 2023, the prevalence of diabetes in India is 10 crores. And according to the Smart India study, the study found that prevalence of diabetic retinopathy is 12.5% and with 4% having severe diabetic retinopathy. So, what are the challenges in diagnosis of diabetic retinopathy? A regular and repetitive annual retinal screening in all patients with diabetes mellitus is needed, which includes a detailed dilated fundus examination done by an ophthalmologist and with color fundus photography taken by a technician or optometrist, which has to be analyzed and graded by retinal specialist or ophthalmologist according to ETDRS grading guidelines. So, the number of doctors, number of ophthalmologists or retinal surgeons in comparison with the patient load is very less, and there is limited access to specialized care, especially in remote areas, and the high cost of eye exams and subjectivity and human error in interpreting the images are the major challenges. So why AI? The screening itself helps in avoiding blindness among 90% of patients with diabetic retinopathy. So providing an automated imaging system within the easy reach of the patient and developing automated analysis software using computer machine learning or artificial intelligence for analysis of retinal images in patients with diabetes itself will solve some part of the problem. What is artificial intelligence? Artificial intelligence is a simulation of human intelligence processed by software or machines, especially computer systems. In simple words, it means to accomplish a task mainly by a computer or a robot with minimal involvement of human beings. The types of AI includes machine learning, deep learning, and neural networks. Machine learning algorithm identifies patterns in data and make predictions based on those patterns. Whereas deep learning is a subfield of machine learning which is particularly effective at learning from large amount of unstructured data like images, text, or audio. All the AI system needs a proper training and validation. The AI system start by learning from a database with the simple targets. After this, they are trained to improve, becoming more accurate and efficient. This is done by bombarding the AI software cloud with a large amount of data, and they learn to identify from seeing the pictures, and by improving training after training, the validation process done. Using advanced math and neural network, the system can understand complex relationship between variables and evaluate different possible outcomes. So in diabetic retinopathy, firstly, the machine after being exposed to a lot of annotated images learns to identify and grade diabetic retinopathy by itself. The software can automatically analyze retinal images and provide the grade and severity of diabetic retinopathy and referral recommendations. So in the clinic, when a patient comes to you with the diabetic retinopathy, the technician can take a fundus photograph, and these fundus clinical photographs are uploaded into the AI software cloud, where this software itself identifies diabetic retinopathy and classifies and grades and whether it is referable or non-referable, or with diabetic macular edema or not. And this diagnosis we can it's sent to the clinician sitting in the clinic. The clinician can provide a counseling regarding the condition of the patient, or if needed, refer to the higher center. So the effort or manpower taken will be very less than the routine examination done by an ophthalmologist. What are the techniques used in diabetic retinopathy diagnosis? It's AI-based systems that detect retinal images using standard 2D images, or AI algorithms assess the OCT scans for retinal thickness and structure changes, or AI-driven software helps in automated screening, improving the efficiency in large-scale screening programs. The advantages of AI in diabetic retinopathy includes early detection, accuracy and consistency in getting the results, and the cost effectiveness and scalability. The case studies and real-world applications, and IDX-DR is the first FDA-approved AI system for detecting and grading diabetic retinopathy. And Selena is a Singapore eye lesion analyzer. It's used in their national program of Singapore for grading diabetic retinopathy. And Arvind in India, Arvind Eye Care System already started AI system along with telemedicine for screening diabetic retinopathy in underserved regions. So in addition to diagnosis and screening, AI is useful in staging and classification, lesion analysis, functional assessment, personalized treatment planning, and progression prediction. The challenges in AI in diabetic screening includes the need of high sensitivity to sight-threatening diseases, the high specificity to limit the false positive referrals, and a good data quality is used for validation and training. Generalization into the diverse population are still under struggle. Regulation and ethics regarding the patient private data privacy, and integrating the health with the existing healthcare system is another challenge. The future directions, the ongoing advancement in AI and deep learning models will improve the accuracy and diagnostic capabilities. Integrating with telemedicine and AI can provide a personalized treatment plan depending on the patient data. To conclude, AI is offering a more accurate, cost-effective, and accessible care. Early detection through AI can prevent vision loss and improve the patient outcomes. The future advancement in AI will continue to enhance the healthcare for diabetic retinopathy patients globally. Thank you for your patient listening.